This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat for Tuesday, January 9, 2024. I'm Len Sierra, and I'll be moderating today with a little help from my friends. We want to acknowledge and thank our sponsors, as we always do, and they are Bayer, Pfizer, Myovant, Janssen, Myriad, Telix, and Foundation Medicine. And I hope I got that straight.
Blue Earth?
What's that?
Blue Earth?
Blue Earth, okay. Got to add that one.
How about Novartis? Is there any kind of update there?
The update is
I know it's only
that
Tuesday, but
the update is that after telling us that they couldn't deal and we shouldn't apply for a sponsorship in 2022, they led us to apply for a grant in 2023, which they then turned down. And then as of this morning, they're saying, well, we should have applied for a sponsorship. So by the end of this week, probably tomorrow morning, I will get them a sponsorship application, and then we'll see.
This conference will now be recorded.
Oh my
Wasn't
God.
me. I didn't touch anything.
Okay. Who is waiting? I don't know who this waiting for CRTC is. We don't know who to. Can anybody figure out who that is? And somebody must have. I don't know what's going on there.
I'm sorry, folks. I just accessed the meeting,
Okay,
and I'm
that's
still.
what it was.
Guess I need to turn my phone off.
Yes.
I apologize.
That's okay.
I only have a third grade education. I'm going to try the microphone here, and then that's probably what caused the feedback.
Yes,
Yeah.
it was.
Okay, so should I hang up the phone now?
Yes,
I'm
try
thinking
and
yes.
yes. Okay, now say
Can you hear me
something,
now?
Tom. Yes, we can hear you now. You're in good shape. You're good to go.
Awesome.
Yeah. You have a newbie special pass. So as I was saying, we will get something off to Novartis and let's see which strings they can pull this time around. But yes, thank you for asking. It has been very frustrating. And I am going to meet with Novartis in person at GU ASCO. So
Okay, we're off to a smooth start. Let's go to John Io. Raise your
AO.
hand again, John. Oh, there you are. Okay.
Yep, John AO. Yeah, I was trying to
Yeah.
be the worst lighting possible. I found a place in here with the sun hitting me right in the eye, so I moved to a new spot. So
Okay.
hopefully
All
that's
right. So,
okay.
John, I have a series of questions I'm going to go through so we can get your profile
Okay,
and help you out. So, how old are you?
62
62. And where do you live, John?
in Rockwall, Texas.
Texas. And how'd you hear about AnCan?
Through Steve.
Oh, yes, Steve. Okay. So at the time you were diagnosed, how old were you and what was your Gleason score?
59, Gleason 8.
4+4?
Yes.
And what was your PSA at diagnosis?
PSA was like 12.5, so it really wasn't all that
Okay.
high. And so that was after the biopsy. Yeah.
Yeah. Okay. Did the
Adenocarcinoma.
biopsy reveal? You had
Adenocarcinoma.
adenocarcinoma, but did you have scans before
I had a
the?
CAT scan right after that showed no margins, that it did not go anywhere. That was still
Okay,
in the
just the
capsule.
CAT scan. Okay. So you went first to a urologist, and who was that, and at what institution?
It was a urologist in Grapevine. I don't remember his name. That's where I started. And then I ended up with a urologist in McKinney, Dr. Stringer. Um, and then that's when, I talked to several people, UT Southwest, and I did a lot of research at the time on what to do with this thing. And so decided to take it out.
So you had a prostatectomy when?
May of 21.
Okay.
So after that,
And
we did
what was your post prostatectomy PSA?
less than 0.1. So it was
Okay.
undetectable we measured it every 6 months, and it was
Right.
undetectable until May of this past year.
May 2023. Okay.
Yep, and it went to 0.2. And
Okay. And
then
then
we did it again in November, and it went to 1.7. And that's when I had the PSMA PET scan.
November 1.7 PSMA PET, and what did that show?
It showed that it had metastasized to lymph and bones and the prostate bed.
Okay. Up to that point, had you had any other therapy besides the surgery?
No.
Okay, so what did they put you on in November?
Well, we're still working on that. The PET scan was on December the 1st, and since then I've been exploring and looking at options. The challenge that I have is that prostatectomy May of 21. In August of 21, I had a right hip replacement, and that's the symptoms that show up for me is pain in my right leg from that hip replacement. So I'm still evaluating. I'm a natural health person. I'm a natural health doctor, and I'm trying to do as much as I can with the natural health world, but I'm on the verge of, like, tomorrow getting a prescription for Orgovix to start down the ADT path.
Okay, that's it, just the Orgovix, no second line anti-androgen?
Not sure yet. I'd asked him about Xtandi or Nubeqa, but we're not sure. I think he wanted to do this first. So we're looking at that. I'm still trying to figure out financially if I can do that or I have to do the injection, but I'd rather do the pills if I can. But I'm interested tonight to hear from you guys on your experience with that.
I'm sorry, you want to know our experience with
Orgovix.
Orgovix? Okay. All right. I know we have several folks on Orgovix. You want to talk to John?
Before we go there, Len,
Yeah.
who is it? Who is it that's prescribing the Orgovix for you?
UT Southwest. I have an oncology team there, so I've met with several people. Right now, I'm on several different opioid drugs to help with this pain. And I've met with the radiologist, and he said, hey, I can do some radiation and knock out some of these hot spots that are
Yeah,
causing you pain, but I'm trying to avoid
yeah.
that because I can't reverse radiation. So I want to see if I can get the pain down with ADT first.
And who's the lead med on? Kevin, I forget his last name.
His name is Ju Wang.
Okay, I don't know him.
Juewang is his last name.
Okay, and he's a genitourinary medical oncologist?
He's a medical oncologist, yes.
Is he a genitourinary medical
I'm not sure
oncologist?
exactly. This whole team is prostate cancer, so I'm not
Okay.
sure.
Then if the whole team is prostate cancer, I'm sure he is.
Yes.
All right. So raise hands if you are on Orgovix or were on Orgovix. Okay. Tom, you want to talk to John about your experience?
Well, yeah, and I'll go into my journey when you ask me for more detail, but I started out with Lupron injections after diagnosis MRI in late 2019, and
Oh,
Uh,
Tom, let's not uh, digress from just answering John's question. I will get to you. We'll get your full story, but for now,
okay,
just yeah.
Orgovix. Uh, I was prescribed Orgovix, and I had a difficult time with it. I have apparently it's supposed to be taken every day. I take it once a week, and it does create a minus whatever that figure is for testosterone. But I'm also taking Zytiga. So yeah, my experiences uh, uncomfortable. I'm very med sensitive. I'm taking it once a week, and it's apparently working uh, on that
John,
level.
Tom, you're taking Orgovix once a week.
Yes.
Okay,
That's a
Len, let's come back to Tom when
yeah.
we deal with
Okay.
him. Okay,
Let's go to Alan Babcock. I guess Alan, you've been on Orgovix.
Alan, I think Alan's frozen. Steve
Oh, okay.
Nordstrom.
Yeah, Steve, go ahead.
Yeah, I've been on Lupron, Firmagon, and Orgovix, and they all work beautifully. And Orgovix works really well. It's a lot better than the shots of Firmagon. So I don't know what else to tell you.
Yeah,
Um,
well, when I first got diagnosed, the doctor came back and said Gleason 8, and you're getting a shot of Lupron, and I was still glazed over, so I got a 3-month version. So I have experienced it, and I know what it feels like, and it wasn't really horrible, but I've heard good things about the Orgovic. So, is there any? I mean, you take it every day, right?
yes, and the benefit is when you get off of it, your testosterone will recover quickly. And
Yeah.
with
Yeah.
Lupron, it'll hang on for you'll have low testosterone for up to 3 to 6 months, maybe longer. I don't know,
Right.
but
Yeah.
so
Okay.
that's the
So one issue that we've encountered in this group, and we've brought it to the attention of Metavant, or they're now called Sumitovant, is that if you are on a proton pump inhibitor, um, it interferes, it interacts adversely with Orgovix, with Relugolix. And
Okay.
we've had some people that have had some nasty side effects, rashes, and goodness knows what else, extreme fatigue. And it's turned out that they were all on proton pump inhibitors.
Okay.
So so you have to watch out for that. Other than that, I would say that the experience of this group is that it's really it's the LHRH drug of choice if you can afford it, and they'll prescribe it to you. It is a good drug, just like Steve said. We see people's testosterone come down much more quickly and also return much more quickly. So it is the drug of choice. That said, I don't know if Ju Wang has discussed this with you, but the protocol for somebody like yourself is to add a second line anti-androgen as well, as you mentioned.
I'm not sure if he wanted to wait a week or so and do that. I think there was a little bit of a lag because I mean, from the stuff I just read an article, a Harvard review study that showed taking Xtandi by itself versus taking it with one of the testosterone blockers. And, when you take it with the test, did you guys see that study?
We didn't, but we're pretty experienced here in
Yeah, I figured you are.
monotherapy with enzalutamide, apalutamide, and with darolutamide.
Yeah.
Actually, we did
And
see that one, Rick. The
did we?
enzalutamide, it was enzalutamide alone, enzalutamide with an LHRH, and LHRH alone.
Yeah.
And
So
go ahead,
yeah.
John.
Yeah, I was just trying to get, I mean, because that's where I want to get to, I think. And again, I'm interested in your opinion, but from what I've researched, the being on those second generation ones, the Xtandi or Nubeqa or one of those, without knocking out your testosterone, it just makes sense to me that if we can help the cells not absorb it rather than just take it out of the body, it would seem like that would cause less problems in the
Right,
body. But has that
right.
been your experience as well?
Well, this is John. I think if I remember that study, the people on double therapy did the best. The people on Enza alone were in the middle, and the people
Yeah,
that were on an LHRH
yeah.
agonist did the worst. Not that the worst was bad, because it was still decent treatment, but
Yeah, they
according to that, you're better off with both drugs in terms of recurrence in the future.
Okay, because it had like I think it was like 97% when you took two, and if you just did the second gen drug, it was like 92%. So it was really
Right.
not much
No.
difference.
Look, the whole discussion about monotherapy, and I'm sure Len will wade in on this, and it's a real interesting discussion. Um, for a long time in this group, and when I say a long time, I'm thinking back to Al Fat with his monotherapy apalutamide, Len, which was what, 4 years ago, 5 years ago?
Yeah,
It's a long
about
time
four.
ago. Yeah, when Doc. So we've had experience with people just using the second line anti-androgen. We personally, we're not docs, but we've seen good results. We've seen people on monotherapy abiraterone, apalutamide. We've probably got some guys right here, right now, who are on monotherapy darolutamide. Um, I'm not sure if we've had anybody. I think we've had people on monotherapy enzalutamide too. The issue is that it's not it's not FDA approved at this point in time, and the doctors, a lot of the GU medoncs don't want to do it. Some of them will. Some of them are very happy to do it. We've seen great results. So we can't say to you, don't do the Orgovics, just do a second line anti-androgen, but we can tell you what our experience has been, and our experience has been pretty good. And we've had guys who have kept their PSA under control, and their testosterone has been up in the 300, 400 levels. I mean, Len, you were on monotherapy. I mean, I know you're going back on it, but what was your high testosterone when you were on monotherapy darolutamide?
I believe it was in the 400s. Um, and yes, I was on darolutamide, which is new monotherapy for over a year, maybe close to 2 years actually. Um, and then my PSA started rising again, and was scanned. And right now I'm back on monotherapy with darolutamide. And just after 6 weeks, it brought my PSA down to near undetectable. So, as far as side effects go, I don't experience side effects with Nubeqa, darolutamide. Um, so, yeah,
That's
definitely
great.
quality of life for me is better. I'm not sure that would be the case for everyone.
Right. Well, I mean that I'm a unique character. Before November, I don't take any prescription drugs at all, thank God. So I've since then though I've started Prozac because I have a history of depression in my past, and I don't want that to enter into this world. So that's my foundational. I'm doing that, and again, the pain. If I can just get this pain down, did anybody else have pain that took either Orgovyx, Nubeqa, both, and got pain relief?
Well, I've had bone metastases, but I never had pain. So I can't address that. Anybody else?
I have bone metastasis all over my spine and hips and what have you. I have extreme discomfort, but not pain. Early on, I had pain, uh, but I take a lot of natural supplements and things of that nature to
Mm.
natural anti-inflammatories, et cetera, to try to mitigate all that.
Yeah, I mean, this started with the right side of the prostate, and that is, of course, the hip that I had replaced. They're probably connected. I don't know, but that's the issue. Is of course you've got something foreign in the body, and that's a weak spot, and so things show up there. So that's my, if I can get past the pain part of this, then I really want to go walking and exercise again and do all those things.
So a couple of things um, that come to mind, questions for you. First of all, you said you had bone mets. Where were the bone mets, John?
In that femur, in the right leg, and the hip, and in the middle of maybe around T5 or so, and then it actually went up to the scapula just a little
Okay.
bit.
Okay. So you did show Mets in that right femur. So,
Correct.
it could well be the Mets. It may have nothing to do with that, or it could be that when they put the prosthesis in, they aggravated something. The prosthesis that the hip prosthesis. Um,
Yeah, let
that's
me
my
comment on
first.
that real quick, if you don't mind. The pain started maybe 3 or 4 months ago, and so I made an appointment with my hip surgeon to say what's going on. Went to see him, did an X-ray, everything's fine. Here's some steroids, everything will be cool.
Right.
The next week is when I got my PSA test. So
Yeah. Well, I mean, there's a couple of things. I mean, it's amazing your cancer recurred and they didn't test you for 6 months, because they should really have kept a good look at that. And surely by the time it got to 1 point, whatever it was, 5,
yeah,
1.7, that yeah, there was something going on.
yeah,
When did you get that hip? Did you say 2019?
2021, 3 months after the
21, three
prostatectomy.
years ago. So I mean, look, I got two hips,
Yeah,
and um, I don't know. I don't know that the pain is related. The pain is probably much more related to the bone mets.
yeah,
One of the things that I would strongly advise at UTSW is to bring on, even now, a palliative care doc,
I have one.
especially. You have one.
Yeah,
Great. Good job.
I have a Dr. Goswami. So I'm doing fentanyl patches and I'm doing hydrocodone, and that helps
Okay.
me to manage the pain until I can get on one of these ADTs they keep telling me, the oncologists tell me that they will help. The Orgovyx or any of the Luprons or any of the second
Yeah,
gens will help with the pain.
they will. The other thing is that if you don't have that many spots, it's not a bad idea to consider spot radiation to the femur.
Yeah, I looked at that and I had that appointment scheduled, and the radiologist, Dr. Yang, all of these people are great. I can't say enough good things about them, but he said, I really, really recommend you've got to get on ADT. I can go in and put a Band-Aid on this and knock it out. But, again, from a natural perspective, radiation is just, PET scans and CAT
Right.
scans are not good. And so even spot radiation I'm concerned about. But again, looking for your guys' opinion, is spot radiation
Well,
as
spot
bad as the other?
radiation spot radiation is great for palliative.
Okay.
It's a great palliative method, but your docs are all right, are all correct.
Yeah.
You can't manage advanced prostate cancer, as far as I know, and most of us in this group know, naturally. So unfortunately, you're going to have to go, and especially at your age, you're going to have to go on some type of hormone therapy. Could you
Right.
get away with monotherapy? You might be able to. You could try it. Most of the guys go on the double. I mean, the protocol now is to use two, and they go on it for a while. They go on it for a year, 18 months, and then they may come off. And then, you could get to the situation like somebody like Len, who has had a whole number of holidays where he's been on, he's been off, he's been on, he's been off. We can't cure this disease, but what we have to try and do is find a way for men to live with it with the minimum loss of quality of life.
Correct.
And And I think that most of us in this group, if it was up to us, we would probably go with an LHRH. I mean, choice, Orgovix and darolutamide is what we would, if it was me, that's what I would look for,
Good.
Orgovix and darolutamide. And I would stay on that Orgovix for 18 months or so, and then maybe come off the Orgovix and see if I can manage with the darolutamide alone and hope that that controls the disease.
But do
And
them
if I
both.
was having pain, I'd do spot radiation.
Okay. Do them both from the very beginning, though. Don't start with Orgovix. Just do both at the same time if I can get it.
Well, I mean, yes, but at the same time, I mean, if they're 2 weeks apart or 4 weeks
Yeah.
apart, that for us is the same time. It doesn't
Okay.
have to be. It doesn't have to be on the same day. Um,
Okay.
Len or Dr. John?
I have a comment about the Prozac. um, it can interact with many of the drugs that you're considering, either by increasing the QT interval in the cardiogram or by inhibiting one of the enzymes in the liver that metabolizes those drugs. In that regard, the Orgovix is probably better than being on Lupron, but it can also interact with some second line drugs and can interact with your pain regimen. And rather than try to make dosage adjustments and work around that, which would be a very delicate job, I would talk to them about possibly switching the Prozac for a very similar drug that doesn't have all these drug interactions.
Okay. Thank you. Yeah,
John,
I'm on the.
I'd like to take you back to May of 2023 when your PSA rose to zero point 0.2. Did they offer you salvage radiation therapy at that time?
No, he said, let's just do it in 3 months. So part of this is my life has been quite challenging the last 4 years. So I got married in May, and my wife, we went on our honeymoon in Cancun, and she slipped and fell, hit her head, had a traumatic brain injury, and she has been in horrible pain for 7 months.
Oh,
So I've
man.
been trying to take care of her and do everything. And so I just kind of let this lapse because it was like, I can't handle this right now. But obviously now I get to. And so part of it was my fault, and I admit it. You know, he said, let's do it in 3 months. Let's wait 3 months to do another test. And I just didn't. But I'm not, I don't sure if the cancer didn't start right after the prostatectomy because it's so small. The PSA numbers have been, undetectable for 2 years. And I'm not sure that if that's really a marker of the cancer. What do you guys think?
Yeah, definitely. You shouldn't have any PSA after surgery. Um, and when you do, that's a recurrence. And the standard of care is to do the salvage radiation therapy as early as zero point 0.2, which is where you were back in May.
Right.
So I was just wondering if they offered it and you declined it, or it sounds like they didn't. They told you you could wait, but
Wait 3 months. Yeah.
yeah, it really wasn't the standard of care. But
Yeah.
I agree with Rick as to, in your case, you have a distant metastasis to the scapula. I would suggest, well, I would talk to your doctor about taking both drugs, or Govix and Nubeca, if you can get it,
Okay.
because it doesn't penetrate the blood-brain barrier, so you won't get the brain fog
Okay.
that you might get with enzalutamide or
And
apalutamide.
I just want to address naturopath Dr. John. Um, we don't give medical advice in this group. We can't do that, but there are some exceptions. And the other Dr. John happens to be a board certified psychiatrist. So when he gives that input, it is coming from a qualified
Thank
background.
you.
I
Well, I
just want to add,
appreciate that.
I
And
just want to add that.
well, thank you for adding that. And I'm listening, Dr. John, because this is, I've been even just getting on the Prozac again. I took it for the first time 4 years ago when this chaos of my life started with divorce and losing jobs and COVID and all that stuff. And, luckily I had a really good experience for 7, 8 months, 10 milligrams, and it was good. And that was at the time I got the Lupron shot, and luckily there was no interaction. And I do have an appointment with my psychiatrist on Thursday to update her. So thank you for that heads up, because that's my biggest concern. I can deal with a lot of stuff, but the depression, not good.
So let me just give you another heads up on that one.
Okay.
Unfortunately, when you start hormone therapy, whatever it is, it can adversely impact your depression. This is just a known side effect because the testosterone is not is restricted from some of your receptors. Either it can't get to them or you're not making testosterone. To some extent, this may be minimized with darolutamide because it doesn't cross the blood-brain barrier. But for guys who are just going straight on an LHRH, too often we see this adverse impact. In my own case, I've been on an antidepressant, an SNRI, for many, many years. And when I went on the hormone therapy, it did impact me. But thank God I knew what it was, because like you, John, we understand depression. When a man doesn't understand depression and it suddenly hits him, it's very, very scary because he's never known anything like it before. So what I did in my case was just ask for, talk to my doc, and I doubled my dose and it worked fine. And then when I felt better, I would reduce my dose back. So I self-medicated to handle my needs. I'm telling you this because don't be surprised, and talk to your psychiatrist about this. Don't be surprised if you have an adverse impact for your depression from going on hormone therapy.
But can we reverse it fairly quickly?
Well, I mean, I think it depends on the. This is really. I'm going to defer to Dr. John. I can only tell you that in my case, by increasing my dose of venlafaxine, doubling the dose, going from 75 to 150 at the time, I did much better. And then I would stay at 150 until I felt better, and I would just come off slowly. And then the next time I had an episode, I double. But Dr. John, what would you say? This is really up your.
It will probably take few weeks.
If it gets bad, it'll take a few weeks to get out of it.
Yeah.
Oh, wow. That's not good.
So you're still, but it's okay because you're starting now.
What do you mean?
Let's make sure I understood your question. You
My
were
question
wondering,
is, if I take Orgovyx or Nubeqa or both, and I have a depressive episode, how long does it take if I double Prozac or reduce one of the others? Is there a way to get out of it without having to sit in that swamp for weeks?
no, it will take time. Therefore, get your mood stable, get a good solid floor under your mood before it has a chance to do that. These side effects from the hormone therapy, many of them take quite a while to take effect. They sure did with me.
Yep.
So you've got time to get stabilized. You responded to only 10 milligrams Prozac last time, and so you could probably go back on 10 or even go up to 20 if you're a little shaky, and
Well,
then you should be well protected.
I'm on 3. I've been on it 3 weeks now. 10 milligram Prozac.
Okay.
And the
And
first 2 were not good. Again, I had some. It wasn't as bad as the first time I did it, which was horrible because I was already depressed. But I did have some episodes on those onboarding for the 2 weeks, and but now I feel like I'm getting there. So you're saying if I can get to a stable floor with Prozac, then I'll be better prepared for getting on these other drugs.
That's right.
Okay. Yeah, and everybody's different, and it could take. You might not feel the impact of the hormone therapy for 2 or 3 months. Okay. I mean, in my case, I think it was a good 2 or 3 months before it really hit me. And most of the time we don't see people starting hormone therapy and then immediately going into a depressive state. I've seen it a couple of times over the last 14 years, but it's really rare. Most of the people feel this coming on and then they can adjust to it. So it's, it's not like a light switch, John.
Okay. Yeah, thank you. Well, I appreciate
Jim
that heads up for
Marshall, you've
sure.
had your hand raised.
Yes, John. Okay, are you a veteran?
No, sir.
Okay, I thank you very much.
John, would you be kind enough to put your email address in the chat window? The chat window is the two little
Sure.
boxes. You can
Yeah.
send it to me or you can send it to everyone if you're comfortable with that. We will make sure that you get on our mailing list. We send out a reminder before every meeting. We meet weekly. We meet on the first and third Mondays at you're on Central Time, aren't you?
Yes.
Yes. We meet on first and third Mondays at 7 p.m. and first and second and fourth Tuesdays at 5 p.m. And you'll get a reminder, and then it's kind of a newsletter reminder before each meeting. So I see it, and we'll get you on the same is true for you too, Tom, if you'd like to get the reminder before each meeting.
Thank you.
John, I just have one other suggestion for you or question. Have you had any genomic testing?
We did not. No, the Dr. Wang said he didn't think that would be helpful because I guess because the PSA has not been a very good marker. I'm not sure if that relates or not, but I think that's what he said. We covered a lot that day. But he said that, my cancer obviously is not very, related to the PSA. That's how they still measure it. Is that how you guys measure effectiveness, is just testosterone and PSA?
Well, the
Yeah.
Yes,
PSA is
but
the primary biomarker, but
but
it is true that some guys just don't produce much PSA.
He was saying it was possibly because I take so many supplements, herbal supplements, that I was like masking it somehow, and maybe still am. I'm not sure. I take a lot of things, and I'm doing, a bunch of different alternative therapies. So,
so um, I think that you still need, you should still be, the, the, the protocol is that you absolutely should be germline tested to see if you have an inherited mutation. And if it were me, I probably would like to get sequenced, genomically sequenced. You may not have enough tumor in your bloodstream, but they might be able to take a sample from your femur. And I think it's really important, if you're young like you are, to see if we have any specific medicines that are appropriate.
okay.
So I would be talking. I'm going to put a link in the chat window right now for the PROMISE study. If you click on this, you'll be able to get a free germline test through Color. This is a trial that's going on, sponsored by Hopkins and the University of Washington, and it offers free germline testing for anybody with a prostate cancer diagnosis, and it includes genomic counseling. And here's the link right now. If you click on the link, it'll open. You can look at it later.
Okay.
We strongly recommend that. And I would talk to Ju Wang about, genomic sequencing.
Okay.
If you're metastatic, you should be having it. And those are the guidelines. You can tell him those are the ASCO guidelines.
Okay. And there's certain, I haven't really studied much of the genomic part. So there's different drugs then that you would take depending on the results.
Exactly.
Very targeted. Okay.
Exactly.
Okay. Thank you. I
All
will
right,
definitely
John,
do that.
thank you for coming
Thank you.
today, and please come back. next week. Let us know what's going on. And we're going to move now to our other newbie, Tom. Tom, why don't you tell us how old you are and where you live?
I'm 77. I'll be 78 on Friday. I live in Tucson, Arizona.
Right. And uh, what was your age when you were first diagnosed?
It was about, 3 years ago. So I guess I was, 75, 74.
Okay. 74, 75. And what was your Gleason score and PSA?
Didn't have a Gleason score.
Okay. Uh, how were you diagnosed?
My PSA, I was having symptoms. My urologist suggested um, that I have an MRI, and that's where the prostate cancer was found.
Where did they find it?
Um, it had escaped the prostate, so it was, I guess, it was in my bones. You know, I, it certainly metastasized to the bones later
Okay.
time.
And then what treatments did you undergo?
Well, my radiation oncologist suggested um, um, Lupron, so I started taking Lupron injections. I think I was taking the monthly, and then I went to the 3 month originally.
Okay. What year was that you started Lupron?
I believe it was 2020.
And are you still on it now?
No, I'm taking Zytiga.
Just Zytiga alone?
Well, as I said earlier, I'm taking the Orgovix, but I only
Yeah.
take it once a week. And it does, every time I get blood work, labs, it shows with my protocol that I'm suppressed. My testosterone is suppressed. And if you want me to continue, I went on the, I've been, I'm perhaps a lot like John. I'm a kind of an Eastern medicine kind of a guy, if he's still on the line here. So I've been doing, you know, home therapies and et cetera. At any rate, my PSA at the time was about 70, and then it started going down. And um, the Zytiga I started in February of last year, and it immediately, and I can't remember what my PSA, I think my PSA was around 50, and then it went to 23, and then it went to like 13 or 12, and then it went to basically 0.08. The Zytiga kicked in very quickly for me, and and I must say, and I want to share this with you, Mayo Clinic, my medical oncologist at Mayo Clinic suggested, because I'm so drug sensitive and so wanting to do it my way, they found a study from um, Rutgers that said if you could take the Zytiga, the abiraterone, or however you pronounce it, with the 5 milligrams of prednisone with a low fat or no fat
Right.
diet, one
Right.
tablet, as
We're
opposed to
familiar.
the,
We're very familiar with that, Tom. We've been
okay, and it's
familiar with,
worked.
yeah, we've been familiar with that protocol since about 2013 or 14 when they first tested it. So
Pretty
you take a low dose abiraterone with a low fat diet in the morning, correct?
correct, correct. However,
Okay.
my PSA recently in recent labs started ticking up a little bit. And it went to like a 1 and 1.5 or something like that to a 2 or something. It's at 5 right now, so it's ticked up. So my medical oncologist suggested that I double it. And so I've been for about 10 days, I've doubled the Zytiga with the prednisone. I don't know if it's been effective at this point. I'm having
Okay.
labs done next month along with a PSMA PET
Okay.
because I
So
had recently.
couple of quick questions. Is it Dr. Singh you're seeing there?
Uh,
Your doctor at
at
Mayo, is it
Banner?
Dr. Singh at Mayo?
No,
Is it
Dr.
Dr. Singh?
No, Dr. Cassandra Moore.
Oh, you're seeing Dr. Cassandra Moore. Oh, I thought she'd left. I thought she left.
No, she's terrific and she's still there. Great, great
Okay.
doc.
Yeah, she's very good. And so Dr. Cassandra Moore. And the reason that you wanted to come on was you'd like to know about the side effects of Pluvicto. Is that correct?
Yes, but I'd like to give you a little bit more background and I'll give you the cliff notes. I did a course of Xofigo in 2022. I did 6 Xofigo treatments at Banner here in Tucson. And because of my bone mets, I have metastasized bone cancer and things went pretty well. It knocked me out. It was rough. It's nuclear medicine. They're injecting nuclear whatever into your bloodstream. But I had to do what I had to do. That's what they recommended. That's what I did. Uh, and then when my PSA started ticking up, that's when they I agreed to take the Abitaron, the Zytiga, and that worked really well until recently when I had an MRI, a spine scan for some other reasons and what have you, and I've got some new lesions and some issues. I also have a lesion in my left femur and my left hip, and I'm going to undergo radiation on that soon. And I have a PSMA PET scheduled for February 5th.
And just like we suggested for John, we would certainly suggest that you undergo genomic testing also,
I
Tom.
believe Mayo did. I believe that was genomic testing. I'm not very medically literate because, frankly, I try to stay away from it. But um, they did some sort of testing uh, at Mayo when I first met Dr. Cassandra Moore upon my diagnosis early on. Uh, so I don't, but and there certainly was no alarm that sounded. So I really don't get that or understand that.
Well, you don't really need to understand it too much. I mean, did they tell you that you had any actionable mutations, or they said there was nothing?
They said nothing.
Okay. Any prostate cancer in your family
My
history?
father had it. My dad had it.
Huh, okay. Uh,
Any other cancer in your family?
Oh yeah, yeah. Mom had it. They were smokers though. I quit when I was a teenager.
Okay.
Uh,
What cancer did your mom have?
she had, I believe she had lung cancer that
Okay.
metastasized.
Well, the reason we ask is because all of this is part of what's called precision medicine, which is something you might have heard of. You might have heard the term precision medicine. And
Never.
basically, well, it's been around now for probably 10 years, and the idea is that we find treatments that are suited just to you. And there are certain treatments that would work for you, but wouldn't work for the next person over and the icon next to you. And that's
Fascinating.
why we encourage you to see if you have an inherited mutation and to see if you may have made any mutations yourself in your body. And both of those are important. And Dr. Moore has probably done that, but it's good to share the results and to keep you posted.
I will double check with Dr. Moore's nurse to see what that outcome was, if that's what I had, and I believe that's what I had.
Okay, so there are two different tests for you to be clear. There's the test to check if you inherited anything, and there's the test to check if you made anything yourself. Both those tests should have been done for you.
I did one test at Mayo when I first went for a consult. I did not do two tests, unless the same sample was used for both. But honestly, I don't know.
Okay, go ahead,
Uh,
Len.
What I
yeah,
do know
Pat
is
Martin would like to talk to you about his experience with Pluvicto when you're ready, if you still want to
I,
discuss
I,
something
I
else.
am ready because uh, I I feel that downstream I'm probably going to need that therapy if I qualify, and that's a whole nother issue.
I've been fighting
Okay,
prostate cancer for 9 years now. And when I first started taking Pluvicto, my PSA was up in the 12 and 15 range, and they'd measured all my tumors. I've been on Pluvicto for, you get 6 doses of it, 6 weeks apart. I took 3 doses, and then I took some time off for a hospital stay, and then I'm back on it. I've taken one more dose. My PSA went from 12, now it's down to 2.02, and my tumors have shrunk over 28%. So it's been very effective. But it all has to do with do you have PSMA, a prostate specific membrane antigen? That's the only thing that it'll work on. And so they have to test you with that. Um, and so I have I've had very few side effects. Been very good for me. I went through several different levels of chemo, a lot of ADT, um, and this is the only one that has not impacted my quality of life. It's phenomenal. Um,
So you have tolerated it very well,
oh, very well,
and
very
you're
well,
just
much better than
and,
all the others.
and you're just finishing the last course of it.
I get a dose in 10 days and then another one in 6 weeks after that,
That's
if I have
terrific.
enough to shoot at.
Do you have bone cancer
I have I have metastases on my bones,
all over the spine and
um, quite a
is
few
it?
areas,
Yeah, I
quite a
have.
few areas.
Okay. Did you do the Zytiga or Orgovix
Yeah,
or any of that?
yeah,
Okay.
I did Zytiga for several years, along with um, your ADT, the shots. Um, so yeah, I've been through a lot of them.
What about pain? How's your pain?
Uh, Tolerable, and I can get ahead of it. They've given me um, doses in the morning that I can take of uh, oxycodone, OxyContin, 15 milligram extended relief, morning and night. And then if I have breakthrough pain through the day, I can take something. I can take oxycodone 5s and 10s. So no, I have very little uh,
I,
problem with pain.
I was just curious because I don't have pain. I had pain early on before
Hmm.
the Xofigo. I'm very, very cautious with particularly any opioid. And I was taking tramadol. Is that right? Is
Yeah,
that a
tramadol.
Yeah, I was taking like a quarter of a tablet, and if I really was hurting, I would take a half or a 25
Yeah,
milligram. But I have not had a prescription painkiller for God, I don't know, 2 years, a year and a half,
yeah.
2 years.
Well,
It
good
gets
for
to be
you. That's just
a
all the better. Um, no, the Pluvicto, I've had very few pains that I can associate directly with the Pluvicto. I don't have it. The only thing I feel is after I've gotten the infusion for about 3 days, I'll be laying on my bed, going to sleep, and my pelvic floor, I can feel it effervescing, just like if you throw Alka-Seltzer in a bottle, just the bubbles and stuff. I feel that all across my pelvic floor, and I can't call that a pain. It's kind of
Tom,
humorous.
Tom,
Tom,
I gotta interrupt this conversation because we've got a lot of guys to get through. If
Yeah,
you have any
I'm
more
done with
issues,
my update.
okay,
Len,
yeah,
Did I
Len,
get that
may I
one
just ask
question?
a quick question, Len,
all right, go
before
ahead,
we
John.
get off of Tom? When Tom, when you doubled your abiraterone, it sounded like maybe you might have doubled your prednisone as well. I thought I'd better double check.
No, I did not, and I was told
Okay,
not to.
very good. Thank you, Len.
Sure.
and just one other question, and we'll move on. Have you done chemotherapy yet, Tom?
No, and I won't.
Okay, so you're not eligible for Pluvicto at this point until you do chemotherapy.
Well, then,
You would have to do at least one session to get it. Now, there is a trial reporting very soon. It may report at GU ASCO at the end of the month based on doing Pluvicto before chemotherapy, and the results have supposedly have been good. But right now, you cannot get Pluvicto until you've done some chemotherapy.
when you say some chemotherapy, could that be a very low dose and a one-off?
You
I don't
might
know
get
anything
away
about
with it. You'd have to talk to Dr. Moore. But why don't you come back next week? We meet every week. We can talk about this again. You can raise it. But right now, until you've been exposed to chemotherapy. We've had a couple of guys that have done one session, two sessions. It's not normal, but it really depends on how aggressive your doctor is and how much your doctor wants you to get the Pluvicto. We hope that within this year in 2024, that will no longer be a requirement, but it is right now.
I don't think
Len,
it
why
Yeah,
don't you?
Tom, we got to move on. I'm sorry. Come back next week. We'll answer any other questions you have. Okay? We are so far behind it. We really want to try and get to everyone. So thank you for coming, and hopefully we'll see you next week. And we're going to go to Jerry Pelfrey.
Okay, uh, just kind of a quick update as to where I am. Um, Thanks to AnCan and Rick, uh, I went and had a very nice visit with Dr. E and at Houston Methodist, and luckily I am getting off Zytiga and prednisone, and I'm off Zytiga, but the prednisone obviously I have to titrate off of. Um, it was a very good meeting with her. Then I came back and I had a meeting with Dr. Singh at Mayo Clinic, and he agreed with Dr. E, which is to go to Nubeqa or darolutamide, whichever you want to call it, and Orgovitz. But also, he mentioned two studies that he would like me to get on. One specifically, which he really wants, is a new study they're doing with a infused, instead of like Pluvicto, it's an infusion, and I don't know what it is, but it's an infusion, and it's immunotherapy, of course, and then a pill that stops the cancer from growing blood cells or blood, lines for nutrition. I haven't heard yet if I'm on that. And the other one is a gene called SPOP. And I've had that gene ever since the first day that I was tested at Mayo in January or February of 2019. And it's an SPOP study. I don't exactly know what they're looking for on it, but I'm a good candidate for it also. And the only thing I know about SPOP is it means that hormone therapy works very nice for you. And of course, I proved that with where I was in the beginning and where I am now. So right now, between Dr. E and Dr. Singh, I'm kind of waiting to see what will transpire with these two trials. So I'm not really on anything. And Dr. Singh, of course, with this trial, wanted me to stop sciatica also. So it was a win-win there. So that's where I am on that. And real quick, I did, Rick, listen to your video of January 1st. And you guys were all talking about having to go to the bathroom all the time. And I do too. But my wife was talking to a friend of ours and about it, and she mentioned that she takes a pill when she ever travels to help limit the desire to go to the bathroom while she's traveling. And the name of it, and I'll show it to you, is Azo, and it's a bladder control product that is not prescription. And it's for leakage or bladder control. And it's an herbal product. So the other thing is, I've read about it, and there are people that love it and people that have some bad side effects from it. So I'm not promoting it. I'm showing it to you if you want to. I'm going to start taking it. I just got it in the mail. It's on Amazon. It's not very expensive at all. And I'll.
So Jerry,
Why don't you keep us posted on this, Jerry?
Yeah.
You'll tell us how you do.
You're both talking. Wait a minute.
we can't promote herbals that are untested on this program. So yeah, you just let us know how it works for you, and then
All right.
you can report back to
Well,
us.
that's what I was going to do anyway.
Right.
Okay.
I'm going to ask everybody to be as short-winded as you can today because we've got a heck of a lot of people. I have one piece of advice for Jerry, which I'm sure you're going to do anyway, but whatever the trials are that Dr. Singh is recommending, please run them past Dr. E.
Oh, of course. E and I have a video conference right after I talk to the radiology oncologist at Mayo to see about this proton SBRT for my L4. So we're all kind of waiting on that. But I've got a video with her on February 1st. So thank you. I'm
Okay,
done.
thank you. Thank you, Jerry. Steve Rue, you're up next.
Okay. Just real quick, I just wanted to thank AnCan and Rick for pointing me in the direction of Dr. Elizabeth Heath. I have a meeting with her scheduled for the 22nd. So prior to
Good.
that, maybe next week, if there's a smaller crowd in here, I'd like to pick somebody's brain about knowing my background, what I might be asking her about. I can tell you that I'm already kind of interested in the whole somatic testing idea and see what she can tell me about that. But again, I just want to say thank you to Rick for that doctor's name, and she seems like she's really interested in seeing me on the 22nd, Monday.
Fantastic.
So I'm looking really forward to that, getting a GU oncologist to start helping me out. I have a question about the webinar. I think it was bringing lutamine, PSMA earlier in prostate cancer, and I saw that in the email. That's at 9 o'clock my time, night and in the evening. Do you know if they'll have a Cliff Notes? Can we get some kind of Cliff Notes
Okay.
email or maybe a recording of it later, maybe?
Okay. I'm not sure which webinar. Oh, I think the webinar that you're talking about, that's not our webinar. The webinar you're talking about is the one from Australia, prostate.
Yes.
So
Yes.
it will actually be taking place the next day, but it comes to us later in the day.
Okay.
I would recommend you register. And if you register, they will advise you of the recording. I have listened to those prostate webinars before through the recording.
Okay, great.
Len, they send out, you've listened to them, don't they send out the link for the recording from Australia?
Yeah, they do.
Good. Okay, perfect. So again,
Right. Now,
thanks for, yeah,
and now the other thing I was going to say is don't miss our webinar 2 days earlier, also with Dr. Sartor, because that promises to be a real interesting webinar. We're going to talk about something that doesn't get often talked about, which is the interaction between the clinical oncologist, your GU medical oncologist, and the radionuclide doc, because things slip between the cracks there. Because these radionuclide docs, as good as they are, they're not used to clinical practice. And we're going to be focusing in on some of that. And good luck with Dr. Heath. She seems awesome. She seems
yeah.
just awesome.
I think that was perfect advice. And by the way, I loved the quotes that you posted there, especially the Abraham Lincoln. I really enjoyed those two quotes from Abe Lincoln. And I have a solution for the latency for the music therapy question in your email that you had, the issue. If it's a
Okay.
drum circle, have some people use larger drums and some use smaller drums.
Dr. John's
Okay.
making a note.
Okay,
you.
thank you, Steve. Dennis Correa, you have your hand up. What's up?
Thanks, Steve.
That was the message back when Tom was talking, and I sent you a message about it. I was just concerned that we really went down the road there to a lot of detail without establishing a Gleason score for this individual. Biopsy.
You may not have one. A lot of times, Dennis, if men are diagnosed metastatic, there is never a sample for us to determine a Gleason score. So when somebody says they don't have a Gleason score, I immediately assume they were diagnosed metastatic, and so that we don't have one. And then a lot of doctors don't bother to, they don't do it subsequently. I think they should, because I think it indicates it's a guide for treatment, but we didn't pursue it because he told us he was heavily metastatic.
Yeah, it's overall aggressiveness. I mean, that's where it all starts. Okay.
All right. Let's see. Al Latimer, you're up.
Hi, everyone. I have a bunch of questions, but with limited time, let me just do one.
I've had several somatic tests over the years, starting back in 2016, and they've always shown up just with maybe one, maybe two alterations. But my most recent one, suddenly it jumped to 9 alterations. This was a Garden 360. These are all Garden 360 studies, which I guess there is some question about their validity, but we'll assume that in my case they're valid. I'm I'm wondering why I would suddenly have such a change from minimal alterations to many alterations, and I'm wondering if it's been caused by the chemo that I've had since the last test. I mean, between the next to last and this most recent test, and or the Pluvicto, and I was wondering if anybody else has seen their somatic variations change dramatically after one of these therapies. I don't really know where it's coming from. I'm just speculating that that was the one thing that's changed, and maybe that's where it came from.
Well,
And then subsequently, what does this all mean? Um, the cancer has obviously um, diverged more.
so
So
Al,
anyway, that's my question.
some of us have seen your report, and as I recall, I think most of your mutations were what they call variants of unknown significance, which is kind of meaningless as far as any treatment or clinical impact is concerned. We just don't know.
Right.
Um,
Well, except that it now qualifies me for Keytruda because of those as I understand it.
oh, well,
Um,
yeah. I thought you meant the
anyway,
specific.
even if they're of unknown significance, so they do have some significance.
Well, that the tumor mutation burden, yes, that's what you're talking about, the TMB.
Yes,
That is
yes.
significant, and that does qualify you for Keytruda.
Okay. Well, then maybe I should ask the question that way. I've never been TMB high before, and now I am after these treatments. So I'm wondering if these treatments had something to do with it, and I'm wondering if anybody else has had a similar experience.
Well, I can't answer if anyone else has had the similar experience, and people, if anybody has seen a huge increase, significant increase in the number of their mutations after as treatment advances, please put your hand up. What I can say is this: we know fairly confidently that the cancer adjusts to the treatments it's receiving. And the more treatments you give, the more mutant the cancer becomes. And so it's not surprising when you have had as many treatments as you have had, and especially having had 2 rounds of Pluvicto at 2 different times, and all kinds of chemo and other drugs, that sooner or later we're going to see a whole bunch of mutations. So I think that a Dr. Schultz or Singal would say to you, yes, this is what we might expect. The question is, are any of those mutations actionable? And the fact that you have a high tumor mutation burden, a very high tumor mutation burden, is a good sign. I mean, I've seen Dr. E treat with pembrolizumab with people who are 8 or higher, but you still don't have MSI high. And my impression, and it's just an impression, I don't have the statistics, is that to back this up, is that the MSI is more significant than the tumor mutation burden. So my feeling would be, since we know that this pembrolizumab, the Keytruda, or any anti-PD-1 is pretty toxic, and we've had several guys who have not reacted well to it, even though it might have helped them, I would be very circumspect about jumping into pembrolizumab based on TMB alone. And I would recommend getting second opinions on that from somebody other than Dr. Schultz or Dr. Singal. And that's what I wrote to you.
Okay,
You know,
well, so maybe I can follow that up with an email, but perhaps you could tell me who you would suggest that I have another opinion from.
I would go to Dr. E, especially with you in Florida, and knowing that she's treated people with TMB high, because you know she is not adverse to doing it, but she can go through the issues with you. And that's probably, that would be my best guess. I mean, you know, you have other mutations in there. You have a BRCA mutation in there, but it doesn't look like it's significant enough. I mean, I'd be talking to somebody like Dr. E, who really understands these things, about, well, is that BRCA mutation significant enough to consider a PARP treatment or something like that? But a lot of
Yeah,
these mutations that you have, not that they're variants of unknown significance, but they're not actionable,
well,
and that's the issue.
that's correct. But in the meantime, the disease has mutated more, so I guess in the long run, that means it's going to be harder to treat.
The other thing that I really would want to do at some point soon is, you know, try, and Dr. E is a good person to establish this with, is, does she think that you're heading towards small cell type disease? Is it morphing towards small cell? Because if it is, start treating that earlier rather than later.
Okay, well, that's an issue that neither Singal nor Schultz brought up. 'Cause I've talked to them both about it already. They're both recommending the Keytruda sooner or later. Schultz wants me to start it right away. Don't wait. But that's not happening. We're leaving on a trip in a couple weeks for a month, so I'm not doing anything until I get back. But the Dr. Reed thing is a good idea. I'm going to pursue that before I do anything else. And my latest garden thing was before I had the second round of Pluvicto, so I need to have this redone again anyway to see what's happened since.
Yeah, don't have it redone by Gardent. Send it out to Tempus or to FMI,
Okay.
or one of the others.
Well, I guess if I see Dr. E, that she can handle that.
Well, I wouldn't wait. I would do it before you leave.
Okay. Well, that's just a blood test. That's another blood draw.
Yeah, you can do it on a blood draw. Do a liquid test and send it out, and tell the doc you don't want it to go to Gardent. You want it to go to either FMI or Tempus, or I forget the names of the other guys. There's one that starts with an I forget. But
I need a prescription for that.
yeah, your doctor's got to order that for you.
Okay. All right. All right. I appreciate it.
All right, El, thank you. Let's go to Mark Baldridge.
Hi. I was on abiraterone for 8 weeks, and I got periodic blood tests to check my liver enzymes. And after 8 weeks, my AST and ALT liver enzymes really skied high. I was on 1,000 milligrams per day, so I was backed off. So I was off it for a little bit. I was on 750 then when they recovered for a short period of time, and then my liver enzymes were still rising. So I've been off abiraterone for a month, but my liver enzymes, they've actually still been climbing just a little bit. Like most recently, the AST was 65, the ALT was 124, and I'm only on like 5 milligrams of statin. I know that can affect the liver. I guess my question for the group is this kind of common or uncommon to have the liver enzymes kind of spike? And is it unusual that they don't kind of go down quicker to a normal level?
Dr. John, you want to handle that one?
Yeah. Um, Generally speaking, when we see a removal of the cause of the liver inflammation, the liver tests improve within just a few weeks.
Hmm.
So, for example, let's say your elevation was due to alcohol rather than um, abiraterone. Uh, Generally, by the time I got somebody into treatment, by the time I was done with them, the liver enzymes were done in 3 weeks.
Hmm.
Now, with it due to abiraterone, that I don't have the experience to tell you. I've seen 50 cases and it took an average of 6 weeks or something. I just don't know.
Hmm.
But the longer it goes on, the more your doctor is obliged to start looking for other causes of potential liver inflammation. So, how long did you say it was? 6 weeks?
It's been about 4 weeks since I was taken off the 750 milligrams a day,
Yeah,
and
I would just say that if you get to the 6-8 week phase in a person without any symptoms of liver disease, it would be time to ask your doc whether it's worth looking for other causes or not. You should
okay,
get them repeated. I don't know what your doctor is going to do for intervals, but I would think 2, 3, 4 weeks is a good interval to watch them improve.
okay, thank you, Dr. John. Just one last thing. So the doctor is wants me to have a blood draw to check for hepatitis. So anyway, that's I guess one kind of proactive thing he's going to be looking for.
Hepatitis B or hepatitis C could be potential causes of increase in liver tests and liver inflammation, and it has to be ruled out in anybody with persistent abnormal liver tests. So that was
Okay,
a good move on their part.
okay, thank you, Dr. John.
So, Mark, I want to tell you that we've seen this before. I can't remember with who. I'd have to do a bunch of research to see if I can figure out. But we've seen the abiraterone is processed through the liver. That's the reason why you can take it with food and you need less. Because if you take the abiraterone at the same time as you eat, the abiraterone is processed more actively through the liver and you need less, which is why Tom can get away with that lower dose with a low fat diet. Now, we've seen guys, and I don't know if there's anybody on. If there is anybody on, please put your hand up. But we've seen guys who have had liver inflammation as a result of abiraterone. They've responded adversely to the abiraterone.
Hmm.
And if my memory serves me right, it took quite a long time for them to regulate.
Okay.
So, who is your
Oh, Dr. Heather
female?
Chang. Dr. Heather
Who's,
Chang.
so okay, and what does Dr. Chang say about? She's probably seen this before. How long does she think it should take for the liver to regulate?
I have an appointment with her in 2 weeks, so I'll be able to find out from her pretty quick.
Okay, but send her a message. Guys, don't hang around with stuff like this. That's what the portal is there for. Send them a message on the portal. Say, I'm concerned, because we don't want
Hmm.
you to have the anxiety. Say,
Yeah.
I'm concerned. Have you seen this before? Does it take longer? We have in this group. We've seen it, but I just can't lay my hands on it. The other thing is that normally what we see with people like that is they'll switch them off abiraterone and they'll put them on an androgen receptor blocker,
Okay.
like enzalutamide, apalutamide, or darolutamide, because that won't have the same effect because that isn't processed through the liver. Len or Dr. John, you want to comment on any of that?
I agree that if you do need a second line drug, that a switch over to darolutamide would be a great thing. That's what happened to me when I had problems with abiraterone. And I would like to request that if she does tell you how long it takes to go away, If you could drop me a note, tell me what she said.
Okay.
Thanks,
Okay.
Mark.
John, was your ALT and AST high on Abby?
No, my problem was uncontrollable hypertension and swelling of the legs.
Okay. Okay.
I
Anyone
was,
else here? Has anybody
yeah,
else here had high ALT, AST on abiraterone?
I
mine
did.
was transiently high when I was on Zytiga for a short period of time. And even while I was still on it, they already started to come down. So that's fairly common. I don't think it's common for your liver enzymes to continue going higher after you've stopped Zytiga, but that's for your doctor to sort out.
Stan Friedman.
Yeah, I mean, I started out on Abby, and within a couple months, my liver went south. Uh, so we tried to lower the dosage of the Abbey, still remained high. And so I got switched over to Xtandi, and my liver recovered quite quickly. My liver numbers recovered quite quickly after that. And they've maintained, I mean, I now have the after effects of the Xtandi, but my liver numbers recovered.
How quickly is quite quickly, Stan?
Uh,
2 weeks, 4 weeks?
probably within a month.
Within a month. So, Mark, you're still in. This is why I'm pushing the issue. You're still in the ball game here. It's still like within the month.
Okay.
So,
Yeah.
don't get too anxious. That's
Okay.
really what I wanted to pull out of the discussion.
Okay. Thank you. Thank you, Rick.
Jim Marshall, you had your hand raised.
Yes, anyway, I started out on the 4 pills. I did that for two months. Anyway, enzymes went up. I dropped to 3, and after that, I was okay for 5 years.
Wow. Okay.
Okay. We can go next to Jimmy Greenfield. Jimmy, are you with us? Going once, twice, 3 times. We'll get back to you, Jimmy. Let's go to Russ Hoover.
Yes, good evening. My update, which I'm not happy about, but let's go. I started back in June of 2020 with Lupron and enzalutamide and ran that for 2 years with basically getting my ass kicked with side effects. And thanks to Rick and you guys, you got me in with Dr. E. I went to see Dr. E in June of 22, and she took me off both Lupron and enzalutamide and got me on Orgovix and Nubeqa. Those respectively, Orgovix, she kept me on till October of 2022, and the Nubeqa on to December of 2022. So I went from December of 2022 till now with no cancer medications, and my PSA was always negligible. I guess was a pain in the ass that I wanted to know what was going on. So I had asked for and gotten from Dr. E a prescription to get monthly PSA and testosterone numbers. Through the summer, everything was good. In October, and I'm not going to get into the decimal points, but in October, my PSA went to 1. In November, it went to 4. And in December, it went to 19. So whatever I have is back. And I just spoke with Dr. E today, and we're redoing all the tests, and she's putting me back on the Orgovex Nubeqa immediately. That's my update.
Russ, when you stopped Orgovyx and Nubeqa,
At
and you at a time,
yeah,
go
in
ahead.
December of 22, per Dr. E.
So you've been on drug holidays since. Is that right?
Yes, correct.
Okay.
All of 2023 until October.
All right. So hopefully you'll still respond when you go back on it. That's what happened with me.
Mm-hmm. Well, that was my question, Dr. E. Should I be doing this? Should I be doing something else? And
No,
the
no,
way
you're still hormone sensitive. I'm sorry to
I'm
hear that
still,
I'm sorry to
I'm
hear
still,
you've had a recurrence, but Dr. E is assuming that you're still hormone sensitive and will respond just as nicely to those drugs as you did before.
yeah. Well, the thing of it is, all the horror stories I've heard about radiation and chemotherapy, the way I got my ass kicked with Lupron and enzalutamide, I don't want to go anywhere near those if possible. So, any thoughts or suggestions?
Let's not get ahead of ourselves, okay?
Okay.
First of all, let's see how you respond.
Yep.
And if you respond well and you're still hormone sensitive, you're in great shape.
Yep.
And if you don't, then we'll talk about it. The question I have for you is when your PSA went to 1 and then when it went to 4, at those junctures, did you call Dr. E or did you only first call her when it went to 19?
I called her when it went to 1, and she said, don't worry about it. And when it went to 4, the first thing I did is I went back and had my PSA and testosterone run again by a different lab. And it basically came back at the same numbers. I called Dr. E about that, and she said, well, I said, can I give it a month and let's see if it's, just going to keep jumping? She goes, give it a month. And I
Okay,
did, but the problem was it went from a 4 to a 19.
right. So
Now,
I think
if it,
exactly what Len said. You're on it, she's on it, you're likely to respond very quickly. I think originally didn't you have fairly high PSAs all the way along or not? I can't remember.
no, the highest PSA I ever had in my life was a 6.
Okay,
And that was like
okay,
5 or 6 years ago. When
okay.
all this
The other
started,
thing, the other thing I would definitely do now
yep,
before you start the Orgovyx and the darolutamide is I would talk to her about getting a PSMA scan.
already scheduled.
Good. She's
That
on it.
and that, and I don't remember the numbers, but I asked her about the gene tests that you guys are talking about tonight. And I said, these were done 3 years ago. Should I have them redone? And she said, absolutely. So I don't know how the deal works, but they're actually sending somebody to my house to
Yep.
draw blood.
Yep. So that's
Okay.
the Foundation Medicine program. They have a traveling phlebotomist, and they'll come
Okay.
out to your house. And it's
And
it's a great program, and that's only with Foundation Medicine, but that's good.
yeah. And the other thing she said, and I don't remember the numbers, that 3 years ago when they did the tests, they only had like 30 or 40 things they looked at. And now it's 140 some things they look at. So it's getting, I guess, better, more refined. So,
Yeah, it's a
if
little
there's
more than that. It's well over 300 actually,
really,
but yeah,
okay.
but you're in
Well,
good shape. Keep us posted, okay?
Can I ask a
yeah.
quick question, Russ? Tell me about your testosterone. What happened when it was last undetectable, and how high did it go before, and how is that correlated with your PSA?
Okay. Before this all started, before 2020, my T level ran like 650 to 680. And I have history on that going back to 2010, 2011 through my GP. When I got into the Lupron and enzalutamide in December of excuse me, the Lupron, the enzalutamide for 2 years, then the Orgovyx and the Nubeqa for basically 6 months through the end of December 2022. My T number was 5. My most recent T number was 411. So between December of last year and December of this year, I went from 5 to 411. Does
That's
that
your most
answer?
recent. That's the most recent one.
411 in December, yes.
All right. Thank you. It's robust.
All right, Russ, thank you. And we're going to go to Jimmy Greenfield. Looks like he's back.
Oh, there's been a couple of things that interrupted me. I'm sorry, but hi everybody. Are you sure it's okay? How many more people you got, Len?
No, you're good. Go ahead, Jim.
You know I don't want to do this. Okay, so I got labs and I got lipid panel and I got more supposed help on the way from my sleep. It was interesting to hear Jerry, and of course, it was interesting to talk about last week the various issues of trying to get more than a few hours of sleep at a time, which I still haven't quite done yet. A little better than it was. My PSA is undetectable now, almost 3 years post full return of testosterone. And that is, of course, the main thing that I'm happy about. Lipid panel is really good. And I'd like to say that my efforts in bringing the LDL down from a sky high 252 to 74 and the triglycerides to 57 are all due to my fantastic efforts, which means taking 20 milligrams of rosuvastatin and wrapping it in cheese and bacon and taking it every morning, which is about how responsible I am for that coming back. But also talked to my urologist about, just going back and forth with Rick about trying to get maybe the Gentessa, which my insurance does not want to pay for. And they don't even want to pay for my metric. But I think that if the doctor, pushes forward, or he says that if they want to deal with it with him, they can deal with it. He didn't say that about the Gentessa. I think probably my metric is much cheaper. I am having some success with the trospium, so I'm getting sometimes 3.5 hours, which is like amazing to me. I mean, I have not had 3.5 hours of sleep in a stretch for a very long time, so that's how bad off I am. But still working on that, and I'll continue to pursue the, whether it's a supplement, whether it's one of the various bladder relaxant drugs or whatever it takes, because if I can sleep, as I say last week, if I can sleep for 90 minutes at a time, that's adequate but not good. If it's less than that, which it sometimes is, it doesn't matter how many I put together, because sleep cycles are 90 minutes to an hour 10. If I can get 2 or 3 hours or 3.5, I feel completely different in the morning, even if I only get 6 total instead of more. So that's what I'm doing, and I'm feeling very good and very grateful, and always grateful to be with you guys and hear about what you're going through and how much we help each other. That's all.
Well, very interesting statin bacon cheese sandwich you've got going there, Jimmy. Was that recommended by your oncologist, or is that your own invention?
It's recommended by me, I'll tell you that.
All right. Let's see. Gary Z is up next. Is Gary Z with us?
Yes.
Gary, you're muted.
Muted.
Oh, I'm sorry. I'm so sorry. I saw Sean Collins, radiologist oncology, for a second radiology opinion. He recommends 5 days of IRMT radiation for the lymph node that's in the pelvic area, the iliac. This is fairly noticeable, different approach from Inova, who recommended 25 to 35 days of proton beam therapy. I'm leaning towards going with Dr. Sean Collins at Georgetown. 5 days of treatment sounds better than 25 or 35 days, but I realize that's definitely not everything that should be considered. I need to confirm with Dr. Collins what the cumulative grays will be. I know that Inova, their proposal using proton beam was going to be cumulative around 60 to 62 grays. So that's really my update. If there's any of the doctors or any of y'all uh, have anything to share in terms of like the cumulative dosage or maybe proton beam versus IMRT. IMRT is what I had in 2016. Thank you.
What about SBRT? Gary, did they discuss that with you?
That's what Dr. Collins just suggested, Len.
I thought he said IMRT.
Len and Rick, Dr. Collins did say IMRT,
Excuse me, Len.
Okay.
which I understand to be photon, PHOTON. That's
Yep.
what I had in 2016. So, I mean, I was, it was obviously noticeable for me to hear this fairly different approach. Inova system, Dr. Kanani has just left to do research, and they told me the name of the new head of RadOnc at Inova. At any rate, their proposal was proton beam. And remind me, Len, is the SVRT, is that related to proton beam?
No, it's another form of photon radiation like IMRT, but it's much more precisely targeted, and there are typically far fewer sessions required because each session is a higher radiation dose.
Okay, so IMRT is different from SRVT.
SBRT.
SBRT, it's the same type of radiation. It's photon radiation. It's not proton, but it's just more precise, higher dose rate per session, and it's done in typically, I don't know, 4 or 5 sessions. Not how many sessions did they say was the IMRT?
Well, Sean Collins, Georgetown, did say just 5 days. So I may have misspoken to y'all tonight. I'm sorry. I've got to go back and look at my full notes. I know, though, that Georgetown said a total of 5 days, and Inova said a total of 25 to 35 days. And I know that Inova was proposing proton beam. But thank you. I will go back and I'm going to email Dr. Collins to learn which of the two photon, whether it's IMRT or SBRT. Thank you.
So
in terms of your question about what the dose is, we can't answer that. It's simply a matter of what they dial in at the time. So you have to ask them.
Thank you, Doctor.
My own personal non-professional feeling is I have more confidence in the X-ray treatment than in the proton beam treatment, but that's based on nothing. So don't go by that. I would probably
thank you, but I do respect and recognize your, vast knowledge of the human body and physiology. So I appreciate your perspective.
Gary, Dr. Collins usually does SBRT for spot radiation.
Okay.
And so forgive me, and Len, please forgive me. I just assumed SBRT because we've known many people. There's probably some guys in this group right now who have gone to Collins for spot radiation. And for the past several years, I would say 3 or 4 years, he's usually used SBRT and not IMRT.
Okay.
So I think maybe I was just assuming that it was SBRT. I mean, I'm thinking specifically of people like Professor Herb, God rest his soul, who went to him a couple of times. And anyone else here been to Collins for SBRT for spot radiation or not? No, but we do see people. So verify with him. I think you can safely assume that it'll be a comparable amount of radiation, wherever you go. But like we said to you last time, 20 sessions, whether it's photon or proton, to do spot radiation to the lymph nodes sounds like a hell of a lot. And that's why we sent you to Dr. Collins. So hopefully we'll save you some time and I don't want to say some money, but we'll certainly save you some time.
Thank you all so very much.
All right, Gary, thank you. And we're going to go to Jay Newman.
Happy New Year, everyone.
Happy New Year.
Just a quick update. I've been on Lupron injections and Nubeca for about a year, and the Lupron is kicking my butt. So I spoke with my med-onc and said my quality of life is suffering. I'd like to stop the Lupron. And he gave me the statistics. Basically, both Lupron and Nubeca are definitely higher success rates, but still just doing the Nubeca for another year should be pretty good results. So that's where I'm at right now. So I'm not getting any more Lupron injections.
Jay, what's your PSA, current PSA?
It was a 7, 4 plus 3, both nodes.
No, not Gleason.
Oh, I'm sorry.
Yeah.
0.04, undetectable.
Yeah. Okay, good. Yeah.
Quick question. I'm dealing with sciatica, and just wondered if anyone has experienced that as a side effect of treatment or the cancers or anything.
How could you tell the difference between ordinary sciatica, which I have, and the treatment, which I have, the SBRT, and the cancer? I can't tell the difference. I wouldn't know what it is. I don't know. Would you guys know how to tell the difference?
I wouldn't either, but it's just started like a month ago.
5 days after the shot.
Coincidentally, it was 5 days after my last Lupron shot. I don't know if that's significant or anything, but
Did
after
you
the
get the shot in your butt?
Yes, in my butt.
On that side?
It was on my left side, but the sciatica is in my middle of my back and down both legs.
Probably not the shot.
Well, of course, being on hormone therapy for long periods of time, you have muscle atrophy.
Yes.
And once you have muscle atrophy, that's not good for it's affecting the muscles that support your spine. And so that could have caused the sciatica.
Absolutely.
So I would like to say something about this monotherapy. There's actually a trial being designed right now for monotherapy darolutamide. We've encouraged Bayer to do this for how many years, Len? 2 years, 3 years?
Yeah, at least 3.
We probably have more experience of monotherapy darolutamide in this group than any other support group in the country. And you heard the discussion earlier on when we were talking about monotherapy and enzalutamide. It's probably a good option, and hopefully you will have less side effects, but you're still on hormone therapy. And you just have to take that into account. And, we can't tell you whether what you're experiencing is due to the Lupron or what you're experiencing is due to the darolutamide, but we can tell you that if you mix it up and change it around a little bit like you have, you may do better. And Len is a terrific case in point. Right. Len?
Yeah. After being on 21-month drug holiday, I went back on darolutamide, and I'm still responsive to it. So it does the job for me, but like we always say, everybody's different.
Right.
I have no hot flashes, uh, no no fatigue like I would have on an ADT drug. So yeah, works for me.
Is there any time frame before the effects of the Lupron leave the body?
Well, it depends. See, like you'll continue to have hot flashes if your T levels remain low. So a lot of it depends on the recovery of your testosterone levels.
Okay.
And our experience in recovery of testosterone, there's a lot of research. There's actually a paper that just came out on that somebody sent me, but I can't remember what it said. Maybe one of the other Brains Trust can remember what that one said. But it's so variable. Some guys, especially the older you are, it can take forever. I mean, Dr. John's been real slow. Other people, it comes back quicker. One thing we do know, if you have to go back on it, try and get back on Orgovix rather than on Lupron, because it comes back quicker with Orgovix than it does with the injection.
Okay.
But
Thank you.
it could be a year. It's not going to be instantaneous, Jay. I wish we could tell you it was.
Oh,
But
that's what my med-onc said. Could take up to a year.
the rough rule of thumb is twice the amount of time that you were on it for it to come back. But that's really a rough rule of thumb. Cliff, go ahead.
Yeah, I went off of I took a drug holiday in November, and my hot flashes are almost gone. And I mean, I have maybe one every so often, and my energy levels picked up again. So it's been what, 2 months, December and January, and I'm feeling
That's
better
great.
already.
Were you on Orgovix or were you
No,
on
I was just on regular ADT, Lupron and
Lupron?
abiraterone.
That is great. I mean, you are way ahead of the game for most people.
I'm feeling, I'm coming off of my prednisone. I'm down to a half of a pill, right now. So that's working out pretty good for me.
Yeah, I had my last 90-day Lupron last April, and the hot flashes have diminished a bit, but they're still there, but it's gradually going down.
And what's your T level, Herb?
The last T level was up from virtually undetectable to I think it was 160 or 180, something like that. It was heading back up.
Yeah. All right, you're getting there.
Yeah. And PSA was, the last test was 0.03, and that was down from 0.05. So T level is going up, PSA is going down. Best of both worlds.
That's great.
You bet. Very good.
Thank you.
All right. Let's see. Julian, you are up, brother.
Okay, can you hear me?
Yep.
Okay, I had my blood work done and everything looks really good, and my PSA is still undetectable, but Dr. E did a new test on me. I don't know if y'all have heard of it. It's carcinoembryonic antigen, CEA. And it was right in the middle, so it looks like I'm pretty clear from my cancer.
A bit of an unusual request by Dr. E.
That's the first time she's done that test.
I mean, especially when you said your PSA is undetectable, right?
Right.
I think they sometimes use that as a marker for neuroendocrine, but I mean, it's a biomarker in many different cancers. It's not specific to any one cancer.
Right,
Anyway,
right.
curious. So came out in the middle. You said normal, in other words.
Yeah, yeah, normal, very normal.
Okay. Anybody else have a comment on CEA testing?
She was taking a long shot at something.
Yes, she was.
Yeah,
But you want
yeah.
be very careful.
Yeah.
All right.
Julian, are you so your PSA is less than 0.1, and how's your testosterone doing?
It's at 149. It went up a little bit. It was at 125. Actually, it went 155 and came down to 125, and then now it's back up to 149.
Okay. Okay. Well, like everybody else that we know who sees Dr. E, you're in good hands. Go ahead, Len.
I see you
Yes.
next Tuesday.
So last but not least, we have Bob McHugh in New Jersey. Go ahead, Bob. We can't hear you. You're muted.
Rather be last than least.
That's right.
My just very quickly, I appreciate your endurance. It's been a long night. My PSA went up, tested last week to 1.1 from 0.8 3 months earlier, and very stable at 0.6 for over a year after spot radiation. So clearly it's on the march, and I'm assuming that this group will tell me that it's scan time, and I'm meeting with my oncologist tomorrow, Dr. Geinesman, and at Fox Chase, and ready to get back on the treatment treadmill.
Okay, well, Bob's already heard my opinion, so anybody else, go ahead.
Yeah, I mean, what I'm hoping is that we can see one little spot. This is probably what Len said to you. We can see like one little spot on the PSMA scan. You can get it zapped because there isn't much else going on, and we'll get you another year before you have to do anything more. That's what I'm keeping my fingers crossed for.
Whack-a-mole, as you so eloquently call it, Rick, right?
Well, you know, the good news with you is that nothing, it's not too aggressive. It doesn't move too quickly.
No, it does not.
So there's a real good chance that, you know, at 1.1 we'll be able to see something. And Len, was that similar to what you suggested?
Well, I didn't go that far. I think I just told Bob I would push to get the PSMA PET scan now. I wouldn't wait.
Right.
And you know, we'll see what it shows. But yes,
Well,
of
good.
course.
Unless somebody else has some words of wisdom, I'll just say thank you. And of course, Dr. John has always been a key, very trusted advisor too.
Thanks, Bob.
Dr. John, do you want any advice to Bob right now about the scan?
No, I agree. Let's take a picture and see if you can do the same thing over again. Other than that, back to ADT.
I'll report back when I get the slides from Photomat.
And I want to give kudos to Len, my fratello Len, because it's only 12 minutes after we had a huge number of people. He got through everybody. He is remarkable. And he put up with my kibitzing. So I think he's done a fantastic job today. I'm going to add my hand clapping to Len. Next week, it won't be Len. It will be Peter Kafka from Maui back in the chair because Peter and Len switched this time around to accommodate Peter. And that's it. I hopefully did we get to everybody?
I'd like to just briefly check in with Bill Franklin. We don't often get to see Bill. You have anything you want to say, Bill?
Yeah, I'll just give a quick update. Actually, there were 38 guys on when I logged in at about 7:12, 7:15, whatever time that was. So yeah, you that's impressive, Lynn, to get through that number in that amount of time. So yeah, I talked to Rick a little bit today about this. We didn't get to discuss it last night because I let a lot of the new guys talk, uh, and it wasn't for their group anyway. But we did bring up side effects from radiation and recurrence sometimes years after you had the radiation. So I'm going on 8 years out from the IMRT radiation that I had, and I was diagnosed today with radiation cystitis because I was having blood in my urine, and I went and got I got my bladder scoped, whichever cystoscopy. Yeah, my mind blanked for a second, so I got a cystoscopy. A guy violated me with a scope today, and at the same time, he found that there was a stricture at the joint where the urethra was joined from the prostatectomy, which I've had no symptoms at all of a stricture. My urine flow's fine, but I could tell he was forcing past something when he put that scope in there. He said, "Yeah, that looks like a stricture. Let me see if I can get the scope past it," and that was an interesting feeling. But yeah, so radiation treatment, something he said can take that my doctor said, and we discussed it last night, Rick, was that something could happen 5 years down the road, 10 years down the road, 20 years down the road. So,
Yep.
uh, but
Yep.
other than that, I'm
Yep.
Yeah.
fine. You guys talked a lot about testosterone, and after my treatment, my testosterone has never been over 400 again. I've got like right at 400, but it's never ever gone over it again. And I've been off ADT for 6 years. But it's like before I was always over 500 or more, but I don't see a difference. I still recover from workouts. I have sex, So I don't know. How high does it got to be till you feel normal, right?
Well, I've heard that the testosterone receptors are saturated at a T level of about 180 or so. Anybody confirm that for me? One of our illustrious docs on the call here, John or Jack?
Don't know.
Don't know.
Yeah, I'd even say that I felt normal when once it got up into like the low 200s.
Yeah, I've
You
heard
know,
200, Len.
Yeah. Okay.
I
Same
have two,
ballpark.
Lynn, last week.
What was that, Jim?
Um, I heard that last week, 200.
Okay. Yeah. Okay, good. So there you go. All right. Well, it's good to have you back, Bill.
thanks.
See you, and we'll have to get together sometime before I leave in April.
Yeah,
And
actually, I'm headed down that way in February, so I'll see what I can do.
yeah, maybe Bob McHugh will be with us too. Is Bob still? Yeah, there he is.
Yeah,
And
cool.
who else?
Where
Pete.
are you, Len? Where are you?
I'm in Venice, which is just south of Sarasota.
Oh, that's right. I hate you. Never mind. I don't want to talk to you about that.
Yeah.
I hate you for that. I want you back up in New England. My wife is cleaning out her mom's apartment in West Hartford, and she's up there for a month because she's in a nursing home now. Her mom. So I'm without her, and I'll go back up there at some point. Maybe I'll wait until you go back because I'm sure not coming to Florida.
Yeah.
Well, Florida's
I want to get
Florida's
You know,
great
I'm
right
Florida.
not in
now.
Connecticut. Jimmy, I'm not in Connecticut anymore. I'm back in New York.
Oh, which
When
part?
I go, yeah, I moved. I moved.
Where in New York?
Do you know Westchester County?
Oh, you well-heeled son of a gun. How about that?
Yeah,
Hats
Mount
off to
Kisco.
you. Well, I'll have to come and see you there. I have to make sure to
All right.
load up my wallet for the cost of living around there.
Yeah, just bring a grapefruit.
And as
Yeah,
far
well,
as
that
your
I can
poor,
do.
as far as your poor wife is concerned, doing without you, maybe Ray and I'll have to take her out to lunch sometime.
Oh, yeah.
Leaving you even more alone.
Listen, I'm going to hold you to it by texting your phone number if you don't have it.
All righty,
Have a nice
guys.
day.
I
All right,
think
guys.
let you all
Listen,
go. We'll see you next
yeah,
week.
You know.
Thank
yeah, we'll
you.
be
Thank
here.
you, Len.
Yeah,
Good night.
Monday night next week. Good night,
Hey, guys.
everybody.